So the talk is kind of split. I will note, like, we have a doctoral program in implementation science at Johns Hopkins where people do it over 5 years. So I'm trying to sort of synthesize what sometimes people do over 5 years into a short talk, but hopefully it just provides a little bit of an introduction into some of the methods that we use, and it'll provide a nice framing for some of the sessions to come. But I'll start by talking really about the definitions of implementation science, what we consider to be some of the important characteristics. And I added this in after the discussions yesterday because I think it really spoke nicely to that intersection between the community that was so well represented and NGOs and government partners. I'll present some of the conceptual frameworks that are used and then talk a little bit about methods and try to give some examples as I go to make it feel a little bit more real and excuse me, and hopefully give ideas of the types of methods that could be used potentially for studies in the region. So I'll just start by giving sort of an overview of a definition within implementation science in HIV, and I think that's relevant just for folks to understand what it is that we're talking about. So I'll just read it out, but it is to say that implementation science is a multidisciplinary field that seeks generalizable knowledge about the behavior of stakeholders, organizations, and communities, individuals, in order to understand the magnitude, reasons for, and strategies to close the gap between evidence and practice in real-world contexts. So I'm just going to say there's sort of three things that I want folks to pay attention to, which is that there's a focus on generalizability, which is like this idea of external validity, i.e. the relevance of the findings that you have from your research. There's a real focus on closing the gap between evidence and what is done in practice. And it's also work that tends to happen in real-world contexts, i.e. in real clinics, et cetera, as compared to more, examples that are more sites that have been set up only for the purposes of research, which is common within clinical trials. Broadly, implementation research includes, if you're familiar with sort of the T1 to T4 translational research continuum, this includes T3 and T4 studies, which are dissemination and implementation studies. It also includes quality improvement. Often people have talked about operations research and includes elements of operation research. And really it includes a sort of a structured and systematic approach to monitoring and evaluation. So I'll just say there's a few characteristics that I think folks in the field think that it is important to highlight. And so one of them is that, if we're really considered the outcome here being directly informing a policy or program, it's really important that you say that there's sufficient evidence to support that policy or that program. So then it really begs the question of what is sufficient evidence in order to inform a program. I think one of the things that we want to keep in mind within implementation research specifically is that often within research there's a fear of failure or non-impactful studies, right? So often when we do studies, we only report it if its P is less than 0.05 or you have some significant finding. And I think within implementation research particularly, it's really important for us to be transparent in what works and what doesn't work, again, so that you can directly inform a program and not inform a policy or program with something that might not work in real-world settings. So what does that mean? It means that you should be transparent about whether the processes that you use were adequate, whether your conclusions are justified, the repeatability, and again, I think it's really important that we're not afraid of failure or non-impactful studies and that we really give those the same attention as we would the sort of, the high impact, very significant findings. In terms of the method, I think just one thing I want to highlight about this, again, in response to the conversation yesterday, is that often folks like me sitting in a university come up with research questions very disconnected from the policy world and the community, implementing partners and others. And so we have this sort of traditional approach where we develop a question, we construct a hypothesis, we go through the process of evaluating that hypothesis, and if it works, then we report our results and move on to the next study, and if it doesn't, we adjust our hypothesis and we keep testing. And I think one of the key things that are different within implementation research is even who is on the research team. So in traditional studies, again, it's really just people like me that have MDs or PhDs or other doctoral programs, doctoral degrees thinking about research studies. And within implementation research, you really should construct a research team that is made up of frontline providers, of policy, of communications, of privacy experts, and ensure that they're not volunteers, that they're actually funded members of your research team as anybody else would be. And so we have this sort of range of the types of competencies that one may want to consider having as part of a research team. But I thought it spoke nicely to the intersection yesterday between the community folks and the researchers, and really the fact that all of them in an implementation research study would be represented, even in that initial phase of coming up with the research question. And then the other thing you can see, I'm not a graphic designer, but the idea is that before you develop your research question, you're constantly iterating with members of the community. So you're not just doing what's called passive consultation, where you might post a question up on a website and see if people respond. But you're really in the very early stages engaging with people, and you do that all the way throughout. And it makes it that much more likely that your end product will inform a policy or program if you go through sort of that stakeholder engagement and sort of optimizing research utilization throughout. And so we could talk more details about this, but just as an overview, it's just important to really think about that idea of engagement much earlier in the process than what researchers normally do, which is just disseminate findings when a study is finished. So I'll just say, I think for implementation research, one of the nice things is that you don't have to make up new conceptual frameworks. There are really well-established conceptual frameworks, and these are the three most commonly used ones, which are REAIM, REACH, Efficacy, Effectiveness, Adoption, Implementation, Maintenance, the stages of implementation, and CFIR, or the Consolidated Framework for Implementation Research. So I include these here as a framework. Again, the idea being that these frameworks can help you guide what are the types of things that you would collect as part of a research study, how might you implement, et cetera. And so I just would ask that as folks are thinking about implementation research, if you want to make up your own approach, that's fine, but you should do that with the knowledge of the things that have already been created, because there's decades of work into this. I think another important thing to think about within implementation outcomes, so within research, we tend to really focus on these health outcomes, individual level or population-based health outcomes, like somebody's viral load at an individual level or HIV incidence at a population level. These are things that we feel quite comfortable using within HIV research studies. Increasingly, we see some folks studying service outcomes, like the efficiency of services, either allocative or technical efficiency, coverage, et cetera. Implementation outcomes are disconnected from the actual individual or population level outcome. And so that can sometimes be hard for people to think about, but it is to say that we could do an entire research study and not assess what is happening to the individual, but instead really focus on how did that individual enjoy the services? Were the services feasible? Were they cost efficient, et cetera? And because there are certain interventions like vaccination or like treatment, where we know that if somebody gets access to a vaccine, we don't need to study whether that vaccine works or doesn't work. We have enough evidence to show that if somebody gets a vaccine, it's going to work. And so it pushes us more into the upstream as to why are some folks getting vaccines or not getting vaccines. And the same thing applies for HIV treatment. It begs the question, why are folks getting treatment or not getting treatment, as compared to the question of if somebody gets treatment, does their viral load go down? And so again, it's a different framing of the research questions, but it's important to think about that these implementation outcomes have been well defined. I think these slides will all be available for folks, my guess is. But this is really more of a resource for you to think about. Again, a lot of work has been put into thinking about each of these different 7 main implementation outcomes and what are some examples that you can use. But broadly, these are some of the most important ones that people tend to focus on are fidelity, which is this idea that you designed an intervention, right? You had in your mind how that intervention would go. And fidelity really measures how closely the field worker out in the different settings actually adhered to the guidelines that you develop. And so, that's one that we tend to look at. Acceptability is one that is an old one, which is basically that you've designed an intervention somewhere, and this is really studying whether that intervention is acceptable to the end users. But there's a whole series of other ones that are important to consider. And again, there's great indicators and sets of indicators that go along with each of them. So you may decide to make up your own, which is totally fine. But I would just really look at what's already been developed first before you consider remaking them. So I'll just talk a little bit about this idea of evidence, because often for folks who have engaged with the WHO or folks who have developed policies, it's always this question about how much is enough evidence, right, in order to support an intervention? And how much evidence do you need to support a policy? And I'll say, traditionally, a lot of the evidence that were used were just process indicators. So, people would look at the numbers of condoms distributed and decide whether that was a good program or not. I think increasingly we're being pushed to the idea of actually, measuring an outcome, which is to say that like what is actually happening with that outcome of interest, and that could be implementation outcomes, it could be efficacy or effectiveness, but the idea being that programs are being asked more to actually look at outcomes as compared to just sort of process or structural indicators. Now, within clinical trials, we know that like double-blinded RCTs are absolutely a gold standard, right? But as I'll talk about soon, like, RCTs are not feasible for most things anymore. And as I'll talk about this afternoon, we can even spend hundreds of millions of dollars, literally hundreds of millions of dollars, and not get an answer from an RCT and be left in a position where the RCT may not have represented the ideal design. And so when we think about sort of evidence supporting public health interventions, we're often in a position where we don't have as much evidence as we would like, but we still need to make a decision. And often we use this thing called the precautionary principle, which is that if we believe that there's a harm of not doing something, but we don't have enough evidence, we'll still do it. So an example in my setting are like restaurant inspections. Like there's no RCT for restaurant inspections, yet we consider doing them. As there's no RCT for parachutes, but yet if you were jumping out of an airplane, you might want one. And so the idea being that often we still have to make decisions in the absence of having the evidence that we would like. There's often this sort of tension between internal validity and external validity. And so, when you see research studies, often randomized controlled trials, there's a real focus on internal validity, which is to say that you minimize the biases between arms so that when you come up with a conclusion, you feel confident about that conclusion. But, really in real world settings, we're more interested in external validity, which is to say how relevant is the finding that you saw to your own setting or to a rural setting or an urban setting or a different population or a different region. And I'll say for implementation research, we tend to really focus on external validity, but it really is, there's a tension between these two, which is to say that the more you control something, the more internal validity you have, the less external validity, and sort of vice versa. And I think for guidelines, you want both efficacy data, which is really internal validity, you want effectiveness data as well, which is more external validity, and then you want some idea about sustainability in terms of cost, especially if these are government-supported programs. So I'll just say that I think there's a traditional approach with research where we do like phase 1, phase 2A, phase 3, and then phase 4 studies. And the best estimate is that this process, from the idea that you have a product to the idea that to the time when that product is in use, is about 17 years. So for example, even if we had a functional HIV vaccine today that was in phase 1 or phase 2A, the earliest that it would kind of come to market might be 2030 or 2031. And even then, we don't know if it would sort of work in real world settings. So I think there's a lot of folks that maybe want to shake up this model and look at implementation issues even earlier in sort of the research pipeline. So even in a phase 1 or phase 2A, you might ask some elements of implementation because it might save you a lot of time in developing a product that would otherwise not be functional in real world settings. So there are examples of vaginal microbicide studies that were supported by governments that were never going to work in real-world settings, but continued being pushed through these trials that cost, again, hundreds of millions of dollars, only for them to find out that nobody wants to use it, and in the end, it doesn't work if nobody wants to use it. So, again, I think the traditional question for programmers used to be like, if it works, i.e., if there was effectiveness, then you would either make a decision to use it or not. And I think increasingly we have these sort of implementation questions of like, sorry, I'm still getting used to this clicker. We have these implementation questions of like, basically like, why does something work? Even if it does work, why did it work? Why does it not work in other settings? And if it does, you then have to ask the question, should I use it? And if so, how would you go ahead and use it? And so, this sort of asks this question about like thinking about guideline development, of trying to sort of integrate these ideas and get away from this 15 to 20 year process of the product pipeline. And so to try to do earlier approaches of like assessing barriers and facilitators to usage, diagnosing quality gaps, and characterizing sustainability earlier in the pipeline. So I would just sort of encourage folks that are involved in those phase 1, phase 2A studies to think about potentially integrating some implementation elements into their work. And so again, to sort of summarize this part, the traditional paradigm was this, like if there's a vaccine, if yes, we scale it up. And I think increasingly we're thinking about these questions. And I have some examples that we could run through, but I don't think there's time. But it's like, can it work? Not does it work? And if it does, what conditions do you need? So for example, a common one was the use of steroids for preterm labor. But in order to do that, you need dating ultrasounds and scanning ultrasounds, et cetera, which may not be available in all settings. So the question is like, if you're doing an intervention, do you have the right conditions? Are you able to measure viral loads? Are you able to do Hep C sequencing, for example, or genotyping, et cetera? So it's sort of asking this question of like, can we meet those conditions? And if so, then we ask the question about whether we should scale up. So I mean, I'll just say a few of these things. When we think about implementation research, right, in general, we sort of think of these 4 Ps, which are, and these may or may not translate well, but are puerile, which is basically that, somebody is holding true to a certain idea and is kind of a research purist, where it's neither has sort of internal validity, and neither has external validity or generalizability. Something is pedantic, which is the idea that, again, you really control it a lot, but it has no real world relevance. And so, we do these really finely controlled studies, and again, there's lots of examples within HIV, probably more than in other fields, because we have the Gates Foundation and others that are willing to invest a lot of money, not from a company that worries about making money, but just for kind of a goodwill. So we get these investments, these huge investments in products that may not be functional in real world settings. There's populist research, which is, work that has has a lot of biases to it, and this is sometimes where we get these research studies that almost could be considered fake news, where they have, interesting generalizability, but actually their internal validity is so challenged so as to really there be any value to the work that they're doing. And ultimately, we have what are considered pragmatic studies, and I think that's kind of the goal for implementation research, which is to sort of get this balance, as I was saying, between internal and external validity. And the way that we do that is really by really specifying our intervention. And so I'll give some examples of what I mean by that, but often I'll just say, when we do especially behavioral interventions, we'll just say like we had a peer-based intervention, and we don't really specify it more than that. We don't talk about whether did the peers get a one-day training, did they have to be high school graduates, did they have to be university graduates, did they get paid on a daily basis, did they get paid only if they saw clients? So the ideas of like how we actually do an intervention takes a lot of details, but we often don't tell people about those details. So it makes it difficult for them to understand whether the work that they're doing is actually pragmatic. I realize I'm going to have to go through. So these outcomes, I'll just say that part of this idea of how we report within implementation research, as I've talked about, I'll just focus on 2 things. One is this real focus on setting, which is really describing the study setting. Was this done in a tertiary care academic center, in a clinical hospital? Was this done in a community center? Really putting the time in and thinking about what things that you had to do in order to make the setting work. There's a lot of information about this idea of intervention specification, as I just talked about very briefly, but really taking the time to specify your intervention, because down the line it will help people use that intervention or decide not to use it based on what information you've included here. And I'll just say we did a research study within HIV, but to say that we actually don't do a very good job, as I said, within HIV of like saying who actually did the intervention and what did they actually need to do. When we say that we did peer educator, is this a 15-minute education visit? Is it a 2-hour visit? Do they spend all day together? So we don't spend a lot of time actually telling people about this in our research studies. We end up only telling people like that we wanted them to increase condom usage or increase testing. So we include our targets, but we don't include a lot of the information on how to get there. And so I'll just say I think that's a real challenge within HIV. So I realize I'm not going to have the time to go through all of this, but I'll just spend a few more minutes and I'll go a little bit over. I'll just say, I think within implementation research, there's a real opportunity to do both qualitative work as well as quantitative work. So often within implementation research, people really focus on the quantitative, but there's a real opportunity to use qualitative work to ensure that like the instruments are measuring the right things. You know, for example, like there's nothing worse than going through a whole study and then at the end of the study realize that your quantitative indicators didn't really do a good job measuring what you wanted them to measure. And some qualitative work up front and looking at measurement could have potentially helped out a fair bit. So I'll say there's a lot of movement right now within the use of observational designs within implementation research. And often that's because experimental designs, especially some of the ones I'll talk about this afternoon, some of the big treatment studies, literally cost hundreds of millions of dollars or tens of millions of dollars. And so they're often not feasible. And there's a lot of things we can't randomize people to. We can't randomize people to not get treatment. We can't randomize people to not getting access to needle and syringe exchange or to methadone or to other things, or to condoms, right? So there's a lot of things that we can no longer randomize people to, and so we have to think of observational designs in order to measure impact. And I don't think that I'll have the opportunity to sort of go through the details of them, but I'll just say there's still a hierarchy of evidence within observational designs and these really new and interesting approaches where we can use like natural experiments. Like for example, if the country of Kazakhstan puts in place a universal treatment strategy, you can use that as a de facto intervention and compare before and after, or even in settings in the country. Maybe in Almaty it was implemented right away, but in rural settings it was implemented slower. So you can use a series of different analytic approaches to use these as like basically natural experiments, as de facto interventions, even though it was an intervention that was happening observationally. So I'll just, I think that this is where you may have heard about terms like difference in differences, where, for example, Kazakhstan puts together one policy, but Mongolia has a different policy. And then you can look at the differences over 2 years in time and see what the outcome may have been in different settings. And so it presents a sort of more affordable way with a little coordination of doing interesting studies that are interventional in theory, but are not intervention in terms of you have to actually randomize either individuals or communities. For experimental studies, I'm really just going to focus on, I'll talk a little bit about pragmatic trials and adaptive designs. I'm going to finish real quick. So a pragmatic trial is one where basically you do this within an existing health facility. You can do this in a large hospital here, but you just change one thing. Instead of people coming in to see a doctor, they maybe come in and see a nurse. Everything else stays the same, and you measure the outcomes of that. So it's a very kind of real-world dynamic in terms of how you're doing the work, but yet you've actually changed, a key part of it, and you can measure the outcomes of it. And I'll say, often we traditionally focus on these like health service and implementation outcomes, but increasingly there's a real focus, obviously, within these settings of like money, right? We're looking at like non-inferiority designs in terms of like the nurse, did people do worse if they saw the nurse? And if they didn't do worse, did the government save money in doing that? And so that you can look at these sorts of approaches that are considered more non-inferiority designs. PROUD was a great example of this. PROUD was the study that was done in London for PrEP, one of the initial ones. PROUD was a really beautifully done pragmatic trial where people presented to STI clinics and were either given the option of getting PrEP or delayed access to PrEP. So it's one of the big studies that we use, and I'm not going to go through it, but I'll just say that like this was just people presenting to an STI clinic, and the way that they did it was just done in a way that was really beautiful to be able to look at differential HIV incidence, even though that wasn't their primary outcome. And so I'll just say I think it was a really nicely done pragmatic trial. Effectiveness implementation studies, basically I just want to mention these because you might hear about them. This is probably the most commonly used design within implementation research, and it comes in sort of 3 forms, which is that, it comes in 3 forms, and it basically is how much you're prioritizing measuring effectiveness versus implementation outcomes as part of your trial. And I'll just say this could be an example whereby in a type 1 design, it's really this is a traditional RCT, right? There's a traditional RCT, but you just include some measures of implementation in there as part of your RCT, Whereas in type 3 design, your first priority is really implementation, but you might include a population level outcome like population level viral load as part of the design as well. So really the idea is that you balance both effectiveness outcomes as well as implementation outcomes. Step wedge designs are also an increasingly used approach where we heard about this from Virginie yesterday in Paris. They have 7 different regions, and they implemented, a new treatment strategy in these different regions. And all you can do is basically space how you're implementing into the different regions, and you can measure outcomes as you scale up an intervention across regions. Again, you were going to scale up this intervention anyway, so it's just about sort of measuring as you're scaling an intervention, because as we know, we can't go from an intervention of 0 to 100 over a number of days anyways. It takes time to achieve scale. So this is just about being deliberate about how you're measuring that scale. I'm not going to get into the ethics. The most sort of recent innovation are these adaptive designs. So adaptive designs use a series of rules that are developed ahead of time in order to decide how somebody gets randomized. So I'll give an example of a study I'm involved with. These are non-virally suppressed sex workers in South Africa. And so they get randomized to either 1 or 2 interventions, just like any other study. But here what happens is if the people achieve viral suppression through the use of this intervention, then they get randomized back to the standard of care. If they're not virally suppressed after a year of intervention, they get randomized to getting a package of services. So it uses sort of a staged randomization approach based on the outcomes. And I'll say I think it represents a really useful design that allows you to ask multiple questions within a single RCT. I won't talk about power and sample size calculations, but I'll just say that it's challenging, and increasingly we're using mathematical models to help us decide on power and sample size calculations. And then the very last thing I'm going to talk about is de-implementation. And I just want to make this point because I heard a lot yesterday about these very big packages of services. So, we know within HIV that we now have to do a lot of things for a lot of people. But it's probably the case that not all those things are actually effective or important parts of the intervention. And so increasingly people have been studying de-implementation, which is where we take away one particular intervention and see if people do worse. And so these are using these non-inferiority designs. And I'll say in Canada, in the US, these are really common designs now because again, the packages are not sustainable, we can't afford them, and we may need to look at what parts we can actually take away and people really never needed to begin with. So I'll say people get always very sensitive when you talk about de-implementation, the idea that you would take away an intervention or you would study it, but I think increasingly we have to really look at what parts of our toolkit are really most effective and what pieces people need. So then to finish, I'll just say, and I apologies for going late, implementation research really is focused on closing this gap between evidence and what is being done in real world settings. There's always this tension between internal and external validity. But I'll also say I think there's a lot of exciting evolution in the use of both observational designs as well as experimental approaches. So thanks for your time.